I didn't hear the answer to step therapy.
Well, it's frankly a scenario where, especially for the IV medications, ocrelizumab included, even though I think, in all fairness, great data, head-to-head data, and the head-to-head versus high-dose interferon. So very positive, only option if you have primary progressive, really. Even though I also learned that maybe that wasn't, as effective as we'd like to see. But the bottom line is, I think, again, on the IV side, unless you have primary progressive, which there's only one option, but otherwise, if you have relapsing MS, many payers will have some form of step therapy. Typically, the ABCR agents, which are old and many patients have been on them. I would argue also that if an MS specialist or a neurologist is calling the health plan and making the medical director aware that that patient has highly active disease, spinal cord lesions, they may need and get access to these infused drugs.
But does that answer make you happy? If what you tell me is you got to get in and pound this thing with the best drug available in the first 6 months, step therapy is taking that time away.
I don't like that. I totally disagree with that. For ocrelizumab, which was a high efficacy with no special monitoring put in place by the FDA, so they reviewed it and said, this is pretty safe. We don't need to do any special monitoring, unlike the other two high efficacy monoclonals that clearly should be a first-line agent. You should be able to use it first line. There shouldn't be any step edit.
All right, there's another possibility here, or another problem, which is you say it depends on the labeling. And the FDA went in, and I heard this, and they muddied the waters, maybe for better, but they did, because they expanded the indication, all the RMS-approved agents, as an SPMS indication, right?
Active SPMS.
Yeah. So the label's not going to help you.
Well, if you're going by the label indication for a therapy and the physician's checking off the appropriate label for which it is indicated, we can't challenge a prescriber, nor would we, because we're not the expert.
Should the treatment for SPMS and PPMS be the same?
That's a very interesting question, because neurodegeneration seems to be identical in both, and there are trials where they do progressive MS trials, they combine both. In my personal opinion, if I felt confident I had a neurodegenerative therapy, I would think it should apply to both.
And does the RMS indication translate to every subtype?
Well, by the FDA, and who am I to, disagree with them?
When they agree with you.
Right. Relapsing MS is CIS, high risk, and relapsing remitting and active secondary progressive. So that's just about covering
Okay, so
everything.
here we are. You tried to back into a defense position of, well, we'll go with the package insert, but the package insert just blew up. So what's that going to do to your formulary costs?
Well, again, back to these drugs are all high cost, right? I think the bigger question is, what are they doing in terms of changing the outcomes for areas like SPMS, where historically we haven't really had options. I've even heard neurologists talk about how they didn't even want to use the language with patients because they didn't have options. It was almost admitting a failure, if you will. So how are these new options going to change the landscape of a disease that's progressive and evolving, and maybe even beyond EDSS?
And what you're actually implying, it seems to me, is balancing the cost of these agents, which in isolated terms are very high,
Yes.
versus the total cost of this diagnosis on a patient and on the family and on society. And maybe it's a net wash or even a benefit in your formulary.
Yes, and again, defining what is then the goal if it's not NADA, which is certainly a high bar. How do we define what the approach is? How do we define what, when do you see, how do you sequence the options we have? When do you switch? And I think this does beg the need for maybe a greater consistency coming hopefully from the experts, coming from the MS Society, but greater definition of what that looks like.
I'm just going to make the following comment. When you're treating progressive MS, your results will never be as good as when you're treating relapsing MS because you don't stop progression. They're going to continue to get worse. So people talk about, is this justified? Is it worth it? When you have a progressive MS patient sitting across the table from you and they say, gosh, I just heard we have a treatment for my disease. It slowed progression. I really want to go on it. I'm not going to sit there and parse and say, well, it slowed progression, but it really wasn't that meaningful, so I'm not going to bother treating you. How do I not respond to that patient and say, you're entitled to get that treatment and try it?
Well, no, I
You
would
wouldn't
beg
say
to
that?
disagree. No, if there is a drug that is indicated for secondary progressive, I would still say the opportunity has been what has happened along the way. But nevertheless, you now have a patient who meets that diagnosis for which there is a treatment. You're going to have to approve that treatment.
So they backed you into a corner. You're going to go broke.
Again, these drugs are all high cost. And if we're looking at what is it that we're paying in failure, right? These patients are disabled, they're consuming a lot of resources. You know, now maybe they're actually in Medicaid, right, because they've lost their insurance. I think the failure has been perhaps even earlier, right, in the disease paradigm. Is there a failure to diagnose early? Is there a failure to treat with the appropriate treatment? And perhaps demand more in the earlier stage to be able to control these patients.
And that is, I think, a very important thing. I mean, I do think when I agree with Pat Coyle that if a treatment is indicated for secondary progressive MS because it has shown benefits, then certainly this is part of the discussions that we are having. The money in multiple sclerosis is early on, and there I do agree with Pat Coyle that step-edit programs may not necessarily take into account the loss of time because patients will need to have failed in order to move to the next stage. And again, if I step outside into rheumatology, for example, that's not what we want to do. And since the brain may be certainly perhaps even more important than the joint,
Absolutely.
then I do think that a program that brings early effective therapy may perhaps mitigate these discussions around progressive disease for some patients.